So we are going to be talking about pelvic floor issues after pregnancy and what are the things that you need to know. So we are going to first go over what resources are available, what's a urogynecologist, what's a pelvic floor, what are visible versus invisible injuries of vaginal birth, what are the strategies that we utilize at Inova to keep you safe, and the strategies that we have to treat complications of visible injuries, and an overview of just pelvic floor conditions that can affect women, and the strategies to detect and treat invisible complications after birth. So unfortunately, there are not that many resources available to women after delivering their babies in regards to pelvic floor issues. The best resource is probably the Royal College of OBGYNs out of United Kingdom. And they do have OAC Care Bundle on their website. So what's a board-certified urogynecologist? A board-certified urogynecologist or urogynecology and reconstructive pelvic surgeon is a physician who generally has completed 4 years of OBGYN residency, and after that they go on to subspecialize and do 3 years of urogynecology fellowship program where all they are doing is surgery. And then when they graduate, they are not going to do obstetrics, they just do surgery for pelvic floor disorders. Pelvic floor ultrasound and specialization in postpartum issues are not required or frequently taught in urogynecology fellowships or physical therapy schools. So this is a very niche area that has not been developed neither in urogynecology nor physical therapy. So how does birth happens? And how does the baby goes through the pelvis and comes through the vaginal opening? So what I have available here for you is the pelvic floor. So if you just look down at your pelvis and imagine it as a basin or a bowl and fill it up with muscles, that's your pelvic floor. And the pelvic floor is very similar to your diaphragm that you use for your breathing. And it also enables you to have very important functions. Functions that you generally won't be talking about, like urination, bowel movements, or sex, are the things that we talk about routinely at our clinics. So if you come to our clinics, we don't mean to embarrass you, or if you had this presentation, the point is not to embarrass you, it's really just that's what we talk about, and the point is education. So with the pelvic floor, what I have circled here is the vagina, but the right above it, I'm going to circle, that's the urethra, and below it is the anus. And then here you have different parts of your levator and muscle. So this is your pubococcygeus muscle, and this is your iliococcygeus muscle. And this white line here is the arcus tendinius that is on both sides. And this is relevant because when we talk about pelvic floor injuries, this is what gets injured. And then when we look at the vaginal opening through the pelvic floor and compare it to the size of the baby's head that has to go through the pelvic floor to be delivered, you can see the problem. So as the baby moves down through the pelvis, it is going to start dilating the pelvic floor muscles, and the pelvic floor muscles are going to stretch, and the baby's head is going to descend behind the pubic bone and then come down further. And then it would get to the point where it is going to put maximum pressure when it's under the pubic bone and right at the perineum. It's going to cause maximum pressure on all the structures. And this is the time that you're more most susceptible to injury. And where does the injury occur? Well, you can have injury where the levator ani muscles or your pelvic floor muscles are attaching to the side wall, or you can have injury at the perineal area, the area between the vagina and the anus, which is called the genital hiatus. So when we talk about injuries being visible or invisible, the injuries to the perineal area and the vaginal opening are visible to your physician or provider, versus injuries to the levator ani muscles or your pelvic floor are not visible to the providers. So once you have delivered your baby, and you hopefully have the baby on your breast in comfort, the physician or the provider will be looking at the vaginal area, looking for tears that may have extended to the anal area. They would look for tears that maybe are going to the side or tearing through the labia. These tears can extend to the urethra or next to the clitoral area. Or you can have lacerations and tears inside the vagina. So all of these need to be recognized, evaluated, and repaired appropriately. What's under the skin here is also very important, because when we look at the vaginal opening, which is here, you can see that there is intricate muscles, connective tissue, nerves, and blood vessels that are supplying this area. So even though it's underappreciated, it is a very important and delicate part of your body. And again, when the baby has gone through the vaginal canal, first it went through the pelvic floor, then it went through the vaginal canal. Now it's at the opening, the space that it occupies will be this much. And it will be compressing the anal area, perineal area, and stretching all of this. So what is that our providers do at Inova to prevent you from having perineal and anal sphincter injury? Well, we call it safe passages. And I'm going to go through all of these one by one in terms of what safe passages means to reduce visible tears to your perineum and anal sphincter. S stands for start perineal massage at 36 weeks. Doing so reduces the risk of you having perineal trauma by about 50%. And this is really important, that this is something that we see in our area in women who are athletic and they're athletes and they have much stronger muscles and maybe they are not prepared for the passage of the baby. So it's really important to start this process at 36 weeks. And the way you do this, you can do it in a warm bath, where you sit in a warm bath before you start and relax before the massage starts and loosen your muscles as much as you can. You want to make sure you don't have long nails and you're in a comfortable position. If you are doing it in your bed, you want to make sure maybe put some pillows behind you, support your back, bend your knees, get in the position we call frog leg, and then use lubricants such as vitamin E, almond oil, olive oil to start massaging the introitus, which is the vaginal opening. You can use your thumbs where you can basically press on the perineal area for about a minute, press down toward the anal area, stretch that area, don't hurt yourself. And you would feel the stretching sensation and try to breathe deeply through it. Gentle massage will do. And basically, you want to do these for about 2 or 3 minutes and repeat it 2 or 3 times, 2 or 3 times a week. And you can repeat daily if you can, but you don't want to be too overzealous, because the point is for your muscles and your connective tissue between the vagina and the anus to soften up. A in the safe passages stand for alleviate fear and anxiety. Be calm and do not push during delivery of the baby's head unless instructed. Basically, you want to have contraction and then listen to your provider. And this is really, again, especially important. Sometimes patients would see their pelvic floor therapist before delivering a baby to be instructed on how to push effectively. So you want to be able to relax your muscles as you're pushing. Your provider wants to facilitate a face down presentation. And what we mean by face down, we don't mean when the baby is breech and they're coming out with their feet first. That's really important. But we want to make sure that the baby's face is not forward towards your belly. The baby's face, as it's coming out, it needs to be towards your back and towards your anus. And this is important because as the baby is coming under the pubic bone and it's diving through, it's literally bending its neck and it's coming through, and then it goes through some maneuvers to get to come out. And if this is the presentation, it can be very effortless. On the other hand, if the baby's face up, or they may call it sunny side up, and it's facing towards your pubic bone or your belly, as it comes out of the vagina, it cannot bend its neck, and the back of the head is going to put maximum pressure on the perineal area and a much higher risk of injury to the area. We do not use episiotomy routinely. Well, first of all, I don't do deliveries anyways, but the obstetricians do not use episiotomies routinely. And there are specific times that this may be utilized, and we'll go over it later. During delivery, they may use a warm compress to place on the perineal area to support it and to prevent the 3rd and 4th degree lacerations. And we are going to go over this later in terms of what a 3rd and 4th degree laceration is. The other thing that can happen as the baby is coming out, their shoulders can get stuck. And this constitutes an obstetric emergency. So the provider may bring your thighs together or extend your legs to try to increase the bony pelvis so you can deliver your baby effortlessly. And if the shoulder is stuck, they may do some additional maneuvers to deliver the baby. The perineum is always supported, but especially when the baby is trying to come out of the vaginal area, the vagina is literally pushed over the baby's head, and the perineum is slipped under the fetal chin, and the baby's head is delivered. At this point, if the baby is stuck and it's not coming through the vagina and an episiotomy is needed, we always advocate for an episiotomy the way you see this arrow, where we call mediolateral episiotomy. Means that we want to aim away from your anal sphincter so you don't have anal sphincter injury. So why do some women have an episiotomy? Well, your healthcare provider may do an episiotomy if you are having an instrumental or what's called assisted vaginal birth, or if the baby is stuck and the mother or the baby's life is in danger. An episiotomy may also be done if your baby needs to be born quickly or if you are at the risk of severe anal sphincter tear. The delivery is methodical, controlled, and slow, and the baby's head is slowly delivered between the contractions. Sometimes when the baby is not coming or the mother is very much exhausted, a assisted delivery may be performed. What's called a vacuum delivery using a suction cup is used in the case of emergency while supporting the perineum. An instrumental vaginal birth is when forceps or suction cup, or which are called vacuum, are used to help your baby to be born. Suction cups are much safer than forceps for the pelvic floor and are only used when necessary for you and your baby. However, the modality depends on your provider's comfort and the specific circumstances. Instrumental birth is less common in women who have had a spontaneous vaginal birth before. So the vacuum delivery or forceps may be used for fetal concerns, maternal concerns, or the other considerations that I have listed here. But it could include abnormal fetal heart racing, the baby being in an awkward position, the baby is getting tired, or and also maternal conditions where you don't want the mother to push heavily, such as heart disease, respiratory disease, cerebral issues, malformations. So there are a lot of maternal reasons where a provider may not want you to push, and they may try to assist you with the delivery. If there are cuts that we discussed to the perineal area, or if you have had a medial lateral episiotomy, or the cut goes to the side wall, or if there are cuts to the urethra and the clitoral area, or in the vaginal area, again, these need to be recognized and very meticulously fixed. The third and fourth degree lacerations, which are lacerations that go to the anal sphincter, take much longer to repair, and because we take these seriously, they are done much more meticulously when they are performed. This is the classification of various kinds of lacerations that you can have. So if you just have literally skin abrasion inside the vagina, that's what we call a first degree laceration. If it goes deeper to the perineal area and the soft tissue, that would be called a second degree laceration. A third degree is when the laceration is extending to the anal sphincter. And these can be divided to 3A, 3B, 3 and C. 3A is when the capsule of the external anal sphincter is ruptured. 3B is that more than the capsule and 50% of the external anal sphincter is ruptured. So basically, you're going through the anal sphincter. And 3C is when the internal anal sphincter is torn. And fourth degree is when the laceration extends to the anal lining, anal mucosa, and disrupts that area. So the reason we don't want to have OAC, which is obstetric anal sphincter injury, is because these patients can have consequences long term. Depending on the kind of laceration that you have, you may have fecal incontinence long term, and generally we recommend for all patients who have had third or fourth degree laceration to come to our clinic to be evaluated. At Inova, by implementing safe passages over a 2-year period, we decreased severe vaginal lacerations by about 40%, eliminated midline episiotomies, and also our cesarean section rate went down. So now that you have delivered your baby, what if you experience these conditions? What if you have anal sphincter, perineal laceration, or your provider repaired you, but you're having wound healing issues? Well, you may have pain and bleeding after delivering your baby, and there may be healing issues and granulation tissue problem. But if you deliver your baby and now you have a cystocele, a rectocele, or uterine prolapse, you may have pressure, you may feel some tissue coming out of the vagina, or you may simply have no symptoms whatsoever. And the reasons to have pelvic organ prolapse, cystocele, rectocele, and uterine prolapse can be multiple. You may have injury to your levator ani muscles, which are not visible, connective tissue, or both. Also, with the hormonal changes that happens during pregnancy, you may develop vaginal cysts or masses that you did not have before. And these may actually present as prolapse, where you would feel pressure, or again, you may not have any symptoms. So I'm going to go over those conditions one by one, so for you to know what they are a little better. And so here you can see what I'm circling here is your bladder. That's the urethra that brings the urine out. The uterus is here, and then you have the vagina. The vagina is separated from bladder with a tissue that we call pubocervical fibromuscularis, and the rectum is separated from the vagina with a tissue that we call rectovaginal fibromuscularis. So you have this connective tissue that supports the back and front of the vagina, and these tissues actually would come together like this, and they get together with the ligaments that are supporting your uterus and going toward the pelvis. And you have two of these ligaments that are holding up the uterus, and also they're continuous with the tissue in the back and front of your vagina. So you can have a cystocele, which means drop of the bladder into the vagina for many reasons. And you can see on the right side, you have this problem. So you can have injury to your levator ani muscles that would result in prolapse, or you can have injury to the pubocervical fibromuscularis, which is the tissue between your vagina and the bladder. So you can think of this tissue before you deliver a baby as a really nice piece of cloth that is separating the two compartments. And when you stretch this cloth, and would get holes in it, and the bladder would fall through it. So you can have connective tissue problem or muscle problem or both. And that's why we like to do ultrasound on patients immediately after delivery of their baby if they have these problems. Next, you can have rectocele. I'm not going to draw that for you again, but it's the same sort of concept where you have either muscle injury or injury to the connective tissue between your vagina and your rectum. And then what you have is the rectum herniates through the vagina and comes like a ball through the vagina. And if you get a rectocele, it may bother you, or you may have to press on it to have a bowel movement, or you may have defecatory dysfunction. And I didn't say this for the cystocele. Cystocele, you may have difficulty voiding and emptying your bladder as well. And what if you have prolapse of the whole uterus, right? So in this case, you can see that you have prolapse of the bladder here, and you have the prolapse of the rectum. But your cervix is coming out of the vagina as well. So not only you have problem with the connective tissue that was separating the vagina from the back of from the rectum, and also problem with the tissue that separated the bladder from the vagina, but also the ligament that basically went to and this is called uterosacral ligament, this ligament that went and towards your sacrum, this may have a break in it. So you can see I'm drawing it here. There is discontinuity. That ligament is not holding up the uterus and cervix, and it's just basically falling through. So that's a uterine prolapse. And you can have it because of muscle injury or the connective tissue problems that we talked about. You can have fecal incontinence as a result of anal sphincter injury that we talked about as well. You have delivered your baby, but they have told you that there's nothing visible wrong with you, but you're having problems. You have pressure, you can have pain with intercourse, you can have voiding or defecatory dysfunction, laxity of the vagina, or you may be traumatized from the events of childbirth. So, but there are no visible problems because the provider is looking at the skin and that has healed appropriately. So you can have all of these problems because if you have pressure, you can have muscle injury, you can have vaginal cyst or constipation. If you have pain with intercourse or no, or you can have actually low or no sensation during intercourse, this could be caused from either low estrogen from breastfeeding or the levator ani spasm. And we are going to go through this some more. Voiding dysfunction or incontinence could come from injury to the pelvic floor, nervous strain, or cystocele. Defecatory dysfunction, inability to have a bowel movement effectively comes from levator ani injury, anal sphincter injury, nervous strain, rectocele, and perineocele. Vaginal laxity could come from levator ani strain or injury. And this is an important thing to recognize because sometimes women come to us and they say, you know, I just feel like my vagina is laxer than it was before, and I want you to tighten it up. Well, the problem with the tightening of those tissues is that you're just tightening the skin and you're not really taking care of the underlying problem, which are the muscle injuries that the patient has had. And then the psychological problems are really prevalent in this condition because you get in a situation where you know something is wrong. You go see your provider, they cannot find any physical reason for your problem, and that can cause psychological strain, anxiety, and other issues that would affect you and your baby and your whole family. So just going a little more through those conditions, sometimes when people have delivered their baby, what really stresses them a lot is that they cannot pee. This could be due to the fact that they have injury to their levator ani muscles or injury to the anal sphincter. Injury to any muscle would put those muscles into spasm, and then that spasm would prevent you from voiding effectively. So if you have had this problem, we need to see you, and we need to see if you have had any hidden injuries that are going unrecognized. You may suffer from constipation almost for the same sort of reason, because when you have injury to your pelvic floor muscles or anal sphincter, all those muscles go into spasm and you're not relaxing them to have an effective bowel movement. And the same thing can happen if you have tried to have intercourse and just this problem is becoming worse and the spasm is getting worse as well. Nobody talks about painful intercourse from breastfeeding, but this is a real problem where women are doing their due diligence, feeding their baby, and nobody tells them that their estrogen is going down and the vagina is literally acting as if it's postmenopausal, as if you're 50 years old. And you try to have intercourse and it just burns and hurts and it's very uncomfortable. And if you try to do that, if you try to appease your partner or to just try to get back to normal, what would happen is that because you're experiencing pain, you would have muscle spasm. You know, you're experiencing pain, you're seeing your partner, and you're associating that partner with pain, and your muscles absolutely lock up, and you will not be able to not only to have intercourse, but voiding and having bowel movements can be difficult as well. So we really need to see you if this is something that you're suffering from. You may have leakage of urine, and if you have leakage of urine, Some of it can be from muscle stretching and may go away, but literally, if after the first month you are not better, we need to see you and make sure that you, again, don't have injury to some of those vital muscles that we talked about and cannot be seen just with naked eye. Talking about invisible injuries of levator and muscles, we have talked a lot about this. Again, this is the picture I showed you at the beginning of your pelvic floor, imagining it like a basin with all these muscles that are doing very vital function. So there are many different kinds of injuries you can have. You can have like partial injury of your pubococcygeus muscle, puborectalis muscle, both of them, or you can have injury to the iliococcygeal muscle. So these kind of muscle injuries are what we call partial injuries. It doesn't mean the muscle has not been injured. It just means that it would try to heal itself. Sometimes it does, sometimes it doesn't, but we need to follow you to make sure that you have repaired those areas. And then you can have injury also in this area. And then the other thing that can happen is where I have drawn this big arrow, where all of your muscles literally get injured. And this is the kind of injury we call avulsion injury. Avulsion injuries are common everywhere in your body. If your muscle come undone from your shoulder bone, from your thigh bone, etc., those are all avulsion injuries. And these tend to be catastrophic. And if this happens, the patients generally have symptoms immediately after delivery, where they have prolapse, they have incontinence, and a mixture of many of the above. So unlike perineal and obstetric anal sphincter injury, levator and muscle injuries cannot be diagnosed visually following vaginal delivery, and they require ultrasound. So a sudden prolapse, pain, incontinence, or pressure are symptoms of severe internal disruption that we need to investigate. So about 35% of women have pelvic floor. By that, I mean levator ana injury or pelvic floor muscle injury. And from those, about 13% of them are catastrophic, which means that there is a big tear of these muscles. And these issues are not inconsequential. They can happen for no reason whatsoever, which means that you may have delivered your baby totally fine without any complications, and you still have this problem. But there are some issues, like with forceps delivery, you can have levator ana injury. If you have had obstetric anal sphincter injury, your risk of levator ana injury would be higher. If there is any fetal malpresentation, as we talked about sunny side up, if the baby's hand is on the face, the shoulder is on there, or there's shoulder dystocia, those can increase your risk of levator injuries. And also excessively prolonged active labor or short labor can also be associated with this. And these injuries are important because even if they're partial injuries, and if you don't have prolapse short term, they would predispose you to prolapse long term, and short term you will have genital laxity, vaginal laxity. Our pelvic floor therapists generally use our ultrasound data and our feedback to create specialized treatment plans for our patients. The way we do the ultrasound is very different. So just for you to know that this kind of very specialized pelvic floor ultrasound is something that I have taught all over the world, and in all the clinics across the US that they're utilizing this basically the methodology that we have taught them. And it's very different for your GYN ultrasound. When you go and have a GYN ultrasound, which is on the left of the screen, you can see that basically, I'm going to show it to you. So you can see that this is a GYN ultrasound, and like a flashlight, it's looking at your uterus in this area and also looking at your ovaries. So when you have a GYN ultrasound, the probe is literally bypassing our area of interest, which is your pelvic floor. So what we do, we use a very specialized ultrasound machine and probe that rather than looking at your uterus, is looking at your pelvic sidewall. And when we push a button, it goes around and performs a 360-degree evaluation of your pelvic floor muscles. So if you look on the left side, this is what a 3D pelvic floor ultrasound looks like. So this is an amazing modality. It's for those of you who are familiar with ultrasound, it's a very high definition, high resolution probe that is placed literally a centimeter away from your muscles and our area of interest. And because of that, the images that we can get with this modality is much more refined and higher resolution than the MRI. So if you look at the picture on the right, it's so high resolution, you can literally see every single muscle fiber that is going through all these muscles. So very, very fine modality. And we can see your anus, we can see the tissue that supports the rectum, between the vagina and the rectum, and we can see your pubocervical fascia in this area. This would be your urethra, that's your pubic bone, and these are your muscles here. These are your levator ani muscles that we are looking at. So very cool technology, and it's literally the cornerstone of our clinic. And if you ever come to clinic, you may see people from other countries, other states, physicians that are professors, but they're coming here to learn this modality, to take this modality back home. And so here you can see the kind of injuries that we can visualize with the ultrasound. You can see on the left side, again, is normal levator ani muscle. So we can see again here, we can outline the muscles that are normal. And on this side, you can see that we have a disruption of the muscle. And this is literally a hematoma, right? Any muscle that tears, it bleeds. And when it bleeds, it creates a blood clot inside your body that we can visualize as a sign of injury. So in summary, women can have various pelvic floor complaints or presentations that require specialized evaluation and treatment. So basically, I say if anything is abnormal during your vaginal birth and you're not feeling better or getting the answers that you need to see us. Also, it's not normal to have pain and discomfort literally past 2 weeks after delivering your babies, and that requires evaluation. The majority of postpartum women's complaints have hidden reasons requiring specialized care. And by the specialized care, I mean our expertise and also the ultrasound technology that we have. And just remember, Inova Postpartum Urogynecology is perhaps the most advanced clinic in the world, where advanced physicians very frequently come to learn from us. All patients with OAC, which means obstetric anal sphincter injuries, at Inova Health System are asked to be referred to our postpartum urogynecology clinic for evaluation. We generally want to see these patients 3 months after delivery, when things have healed and there's not as much edema and swelling, and the ultrasound wouldn't be uncomfortable. But if any of these patients have issues immediately after an OAC, granulation tissue, wounds not healing, wounds falling apart, we need to be seeing these patients. Having said that, it's important to remember that the last time we looked at our data, even though the obstetric anal sphincter injuries is what we really don't like to see. Somewhere about 90% of patients that are seen in postpartum urogynecology clinic are seen for problems other than anal sphincter injury. And 65% of our patients are self-referred. They find us themselves, they're referred to us. And then the rest of the patients are either referred to us by physical therapists, midwives, or obstetricians. So if you have any questions, I know you have put them in the chat, and I would try to answer them the best that I can. But remember that, again, you are unique and your tissue characteristics are unique, and the injuries that you may have experienced or you may experience would be unique to you as well. So as such, the answers I would give you probably would be very generalized, and to really give you a individualized care plan, we need to see what your actual problem is. Thank you.
Thank you, Dr. Shobeiri. That was a great presentation. Could you stop sharing your slides at this point, and we'll start getting into the Q&A. So the first question is, should women still do pelvic floor therapy even if they don't have the kind of symptoms you described, the urinary or fecal incontinence postpartum? And are there long-term risks of not doing the pelvic floor therapy?
Yeah, I think, our postpartum urogynecology is not even a discipline. It's so much in its infancy. So a lot of the things that we do, we learn it from orthopedics physicians, right? So if you go to see an orthopedist, they image you, they see where the injury is, and they look at that injury and they treat it. And that's really what postpartum urogynecology is. And again, orthopedists rely heavily on physical therapy, right? I mean, we are surgeons, we go put things back together, but you still need to have pelvic floor therapy. And what if you don't have any problems? As I said, you could have problems, you just wouldn't know it. And remember, your pelvic floor muscles have to stretch to beyond their limit to deliver the baby. So you really need to have physical therapy to strengthen those muscles back again. And not only that, a lot of times we see patients and they may have what feels to me like normal muscles, but they cannot make them function normally. Like I would ask them to do a Kegel or squeeze, and instead they're bearing down, or I ask them to bear down and they're squeezing. So they really don't know where their pelvic floor is. And that's some dysfunction that is that develops after vaginal delivery. So doing physical therapy while you're pregnant is important. Establishing care with the pelvic floor therapist at that point is important once you have delivered your baby. Going back to them, because then they know what they started with and what you're finishing with is really important as well.
Is it ever too late to start these exercises?
No, I think the major thing that we have to say is that if things are wrong, or if you have major levator ani injury, those are information that the physical therapist can use to individualize the care plan for you. But you need to see a physical therapist to make sure you have those muscles and you're exercising them appropriately. But at no age is it too late to do pelvic floor exercises. If you don't use them, literally like any other muscle in your body, they're just going to melt away and they're going to atrophy. That's what our body does as we age, especially after menopause. So this just gets more, your pelvic floor health gets more and more important. These are muscles involved for your peeing, bowel movements, and sexual health. So you need to keep them healthy for you to be healthy.
Do you have any special suggestions for women who have had a C-section?
So there are C-sections, and then there are people who have labored, and then they have C-sections. So if you labor and, for example, you have shoulder dystocia or something is not going right, and basically your cervix dilated all the way and you have been pushing, and then you have a C-section, that's a very different problem than if you just have a C-section because, for example, you had a breech baby or some other maternal fetal indication for to have C-section for. Remember, physical therapists are pelvic floor therapists, are not really just taking care of your pelvic floor. They're going to look at you holistically and make sure that, for example, you don't have diastasis recti, right? And then you also just need to remember that with even if you have a C-section, you still, the pregnancy itself, even if you don't have vaginal delivery, you can have postpartum issues. So there are many reasons for you to go and see your pelvic floor therapist, physical therapist, if you have had a cesarean section. One of the things they do is just manual therapy to soften your scars and etc. as well, and make sure you don't have abdominal separation.
For women who are breastfeeding, do you have suggestions for things they should do as they get back into activities like light exercise or sex?
Mhm. Again, I think the um, activities um, you need to do what you can tolerate. And we want you to get back to normal activities as fast as possible to, because, you have delivered a baby, you're trying to get back to your normal self as much as possible. So doing things that help your body and your mental health is really important. With the sex, I think it really requires a major adjustment in the relationship between the couples, because sometimes that's really what has been holding them together, and now they have a baby and they want to get back to what really kept them together. But it's really important for you and your partner to understand that sex can be very uncomfortable if you're breastfeeding and you have low estrogen level. So hopefully that understanding will bring the relationship closer together. There are things I normally say, um, there is really no set time for one person or the other, because sometimes I look at someone 6 months after delivery and they're breastfeeding and their vagina is really, really raw. And I look at somebody who is breastfeeding a month after delivery and the vagina appears very normal. So there are some individualized issues in terms of uh, estrogen receptors and how your body reacts to them that make you more prone to having vaginal atrophy compared to somebody else. The point is that if you try to have sex and it hurts, don't do it, and then come and see us or see your OBGYN. And what we can do, if sex hurts, we can give you some vaginal estrogen cream that is not absorbed in your system, doesn't go into your breast milk. So you can continue breastfeeding, and then that would make your vaginal tissue healthier so you can resume intercourse. But again, if it still hurts, don't do it. Just be patient with it.
Okay. This person is asking with regard to urinary incontinence, is there a difference in how your muscles react between urinating standing versus sitting? For example, should you avoid urinating while you're standing up in the shower?
So it's, I think people do it, right? But it's generally not not what women do. So normally, if somebody come to me and say I'm standing up while peeing while I'm in the shower, and I say why, they're like, well, because I cannot pee while I'm sitting. So so the so it's not bad for you, but we need to see why you are doing that. So if you're standing in the shower and once in a while you're like, I am feeling the water and just have to pee, that's okay. But habitually just trying to stand up in the shower and pee, that's not a normal thing. And we need to see why you are doing it. In terms of your muscle reactivity, your muscles tend to be most relaxed when you're squatting. So the squatting position is what relaxes the muscles to enable you to pee and have a bowel movement most effectively.
What pelvic exercises should women do to navigate a successful vaginal birth after cesarean?
I think that needs to be individualized to you. Um, the the main thing is that we need to make sure that you're able to relax your pelvic floor muscles if you're trying to have a vaginal delivery. And also just need to remember why is that you had a cesarean section in the first place, right? So if there was if you labored again and you couldn't have a vaginal delivery and you have had a cesarean section already, um, if you're going to have only 2 children, do you really want to have a vaginal delivery? Why don't you just have a cesarean section? So I just want to say that if you didn't have a vaginal delivery, that doesn't make you a failure. All we are asking for is all I think your family and your partner is asking for is a healthy baby and a healthy mother. So do what's the healthiest for you. So again, if you had, for example, a breech presentation and you had a cesarean for that, it's okay to have a vaginal delivery subsequently. But if there were some conditions that really necessitated that cesarean section in the first place, I wouldn't question it. I'd probably have a repeat C-section. But that's something you need to be talking to a physician about.
Okay. This next question is about vaginismus, and it's very general. I guess they just want you to comment a little bit more about it.
Yeah, vaginismus is something that we talked about already. The muscle spasm is called vaginismus. And what it means is that if there is vaginal penetration and it's a situation that you psychologically view as unsafe to you, this could be having intercourse with your partner, could be a sexual assault, could be something, could be you had a bladder infection and when you had intercourse, it hurt. If you continue trying to have intercourse despite pain, your brain is going to associate that situation with danger. So your partner that you have loved all this time, you just see their face and you want to have sex mentally, but your muscles have basically clamped down and they are not going to allow you to have sex. The partner may penetrate the vagina and they're going to literally hit a wall that is your spasmodic muscles. And if they try to push past it, it's going to really hurt. Not only sex is going to hurt, a lot of times the bowel movements can hurt. You may not be able to pee. When we see patients with vaginismus, first of all, if you have vaginismus before delivering your baby, you need to see a PT during pregnancy to relax your muscles. And that's really important because your risk of injury of those muscles is much higher than the average person whose muscles are relaxed. And then after delivery, if you have vaginismus for whatever condition that we talked about, it's you need to see physical therapy. And then if the physical therapy is not successful, they would send the patients to us and we do Botox injection of the elevator and muscles, pelvic floor muscles, and relax them. And that's a very effective way of dealing with it. So what I tell people is that, basically go see PT. The PT is going to work you for 2 months. Again, if you are not able to relax your muscles, you're not a failure. This is something that happens, and we have ways of relaxing them for you. The same thing literally can happen to anyone, to any muscles in their body. Your shoulder muscles can go into spasm, and if it's not responsive to PT, some surgeon would take the patient to the OR and inject Botox in those muscles. So the same thing with the vaginal muscles. There's a whole protocol that we follow for vaginismus, and we see quite a bit of vaginismus patients in our clinic on a daily basis, postpartum.
So we're at 6 o'clock, but we do have a number of questions still to be answered. So we're going to stay on another 10 minutes or so and try to answer some of those questions. This next person is asking for urinary incontinence. Is it a symptom that usually starts right away after delivery, or might it not start for 3 or 4 weeks later?
Or you may not have urinary incontinence at all. Remember? So you may have urinary incontinence, you may not have urinary incontinence. I think that the things we talk about here, I just want to mention to you that it's not meant to scare you. It's meant to educate you. So if there's even 1% chance of it happening to you, you won't be surprised and you're prepared to deal with it. So for urinary incontinence, it may happen maybe to about 30% of patients after delivering the baby, and most often it resolves. But as I said, if it doesn't resolve and it's persistent, like past a month or so, then you probably want to come and see us to make sure everything is intact. Sometimes it can be just from stretched muscles. And as we talked about, that's the only way that the baby is delivered, by the muscle that is stretched beyond their limit. As long as those muscles are not injured permanently, so you can rehabilitate them and cure your urinary incontinence with physical therapy. So the other thing I just wanted to add, sorry, was that we are generally very hesitant to do any surgeries on postpartum patients. You know, we try to support them conservatively as much as we can and try to support them past their childbearing ages before we engage in surgeries. But there are some things that are just surgical problems that need to be repaired.
Can pelvic floor therapy be replaced by regular classic gym exercises such as yoga, or even Kegels?
Mhm. Again, in our clinic, we see patients a lot of times that they say, do Kegels, and they're like pushing or they're doing something else. So if you think you're doing Kegels, doesn't mean you're doing Kegels. I love yoga, but I really think it's what's harming going and seeing a pelvic floor therapist. You're going to see them a few times. And if you're doing things right, you go back to doing your yoga. If you are not, then you have additional information to make sure that you're doing things right. But no, without examining, I wouldn't be able to say if you're doing things right or wrong.
This is an interesting question. Is it recommended that we see a urogyne versus a physical therapist?
So I think within the Inova health system, we are very good together. Our pelvic floor therapists and urogynecologists work hand in hand. So if you want to see pelvic floor therapists and they work with you and they feel like you're progressing well, that's totally fine. So the answer to that is no, you don't need to see your gynecologist depending on your problem, right? So, but I think a lot of time it's better for us to work hand in hand, where I would give my opinion and they do what they need to do and we go back and forth. So that's probably the best way of doing it. But if you decide to see me, honestly, I would send you to pelvic floor therapist. And if you see pelvic floor therapists within Inova or even outside Inova, we have really good reputation. They would probably send you to us if they feel like, hey, you need to see us. But you're never wrong to see a pelvic floor therapist.
How serious must the urinary incontinence be for you to be seen by a physician?
Pelvic floor disorders, including urinary incontinence, are quality of life issues that are life altering to a lot of patients, right? So the threshold on what's acceptable to patients is different between patients, right? I mean, so first of all, urinary incontinence is not normal. You were not leaking urine before you delivered your baby. Now, now that you are leaking urine, you need to get care for it one way or the other, because not getting care for it, it's you're going to be wearing pads, it becomes hygienic problem. You can have skin breakdown issues. So it's a quality of life issue. You decide when you need to come and see us, but then at the same time, a lot of times I'm surprised by how long people wait before they come and see us. And there's also this misconception by I don't know, a lot of like primary care physicians, etc., that these conditions are not treatable. So they're highly treatable condition, and we work hand in hand with our physical therapists to take care of you.
This person is asking if pain around the hip bone is a sign of pelvic floor issues.
Pain around the hip bone. That's a very big bone, so it's hard to say exactly what part of the hip bone they are talking about. So I would say that can have literally a long differential diagnosis. You need to see a pelvic floor therapist or someone to evaluate you.
You might have addressed this in your presentation. This person is asking, does a breech vaginal birth cause more damage to the pelvic floor muscles?
Oh. The breech vaginal birth doesn't necessarily cause more damage to pelvic floor muscles. But having said that, I'm not aware of any studies that have studied that specific question. But I don't think they cause more injury unless they have used forceps during deliveries.
Will urethral prolapse reverse by itself?
So I think we need to talk about what urethral prolapse is. There are many variations of urethral prolapse, so it depends on what they're talking about. Sometimes urethral prolapse is the internal mucosa of the urethra coming out. For a young woman, that's not normal. Sometimes it's just because of the change in the genital hiatus and stretching and maybe some muscle injury at the opening of the vagina. The urethra is coming out more. So I think we just need to see what they mean by the urethral prolapse, but depending on why they have it, it has different solutions.
This next question is coming from a fellow physician. And I know it's a woman because she mentions her own pregnancy. She says, I have women across the lifespan coming in with these issues. Would it be worth referring them to your clinic if pregnant or remote from postpartum or even postmenopausal, or continue to refer straight to GYN urology or pelvic floor therapist?
So basically, we have, if I'm not mistaken, 8 urogynecologists across the system. So we have Dr. Jackson in Alexandria, we have Dr. Velgas, Horbach, etc. in Mazlum in close to the Fairfax area. I operate in all the different hospitals, and then we have um, Dr. Gembot and Gerges in Loudoun area. So really the whole area, you have your gynecologist close to you. And the same thing with the physical therapist. We have, I think, like 25 pelvic floor therapists that we actually have trained ourselves, and they're across the health system. So the answer to that question is that you can really refer any of those patients to any of our urogynecologists, and we'll take care of them. If I am trying to make sure that postpartum patients don't wait too long to see me. So for that reason, most of my patients are postpartum urogynecology patients. But if somebody calls me and say, hey, I really need you to see this person that is postmenopausal or has prolapse or has other issues, sure, we'll see them. But we try to match the patients with physicians closest to them, so it wouldn't be inconvenient to them. But for postpartum urogynecology, remember, we have patients coming from California and overseas to be evaluated. So if you're living in Alexandria or living in West Virginia, that's not really too far.
Okay. I'm going to take one more question here. I seem to have lost it. Hold on. What other options are there for pelvic floor issues other than the pelvic floor therapy?
Ooh, that sounds like a trick question. Um, I think it's first of all, pelvic floor issues is a really wide field. So unless I know specifically what you're talking about, I can't say, but I'm just trying to read into the question again. Sounds like a trick question. Are they talking about chirotherapy, chiropractors and things like that? We again, our pelvic floor therapists, we have literally trained them ourselves. I have high faith in them, and those are the people I would want you to see.
Well, I think we are out of time at this point. I want to thank Dr. Shobeiri very much. We really learned a lot. And I'd like to remind our participants that once you leave the webinar, a survey will pop up on your screen, and we'd really appreciate if you could complete it and give us your feedback. One of the questions asks if you want to be contacted to set up a clinical evaluation with our speaker or another Inova specialist. And if you do answer yes, please be sure to provide your name and contact information. Otherwise, your response will be anonymous and we won't be able to contact you. You'll also receive a follow-up email in a few weeks with a link to view the recording for today's webinar. On behalf of Inova, thank you again for joining us this evening.
Thank you.